Get one too. You know, it's incredible how much traction we've been able to garner on mental health awareness month. And now that we're live streaming, there will be others that will be able to join.
Yes.
The event. Now, I don't think we. I have this link here, and we're just the first time we're trying this out, and the hope and idea is that it'll be a reoccurring, opportunity for us to really push a message out that is pertinent. And I now confirm that we are on the YouTube link.
Yes, I can see it on my screen. It says live.
Excellent. And so now I will distribute this to many because they need to also
log in
to see. For instance, a lot of a lot of our Carenodes participating providers are health technology companies, and these health technology companies continue to see the opportunity to get into healthcare and behavioral health as a part of it. And we need to provide them with kind of insight into the workings of healthcare. What should we consider when we talk about behavioral healthcare delivery for a certain population?
Exactly. So, please send me the link if you have it, email or text message also, so I can distribute. I have people waiting to join.
So who do not want to keep the meeting?
This is exciting.
I'm very excited. I'm trying not to fall off my seat. Okay, here we go. I'm also emailing you the link. There we go. Link.
Okay, thank you.
Send. And now I'm posting on LinkedIn. And Alex. Yarijanian of news. Streaming live.
I got it. Thank you.
Perfect. Hashtag mental health awareness. Great. Except I didn't include the list. There we go, analytics. So, it wants folks to go ahead and, engage here. The idea is engagement. So, let us engage, share here. I'm going to share on various kind of company and organizational LinkedIn pages. Okay, well, I'm ready to start.
I am ready too.
We've notified the networks, and I'm sure they'll join and engage with us. So, Dr. Godwin ORKEH, you and I got to know each other by the virtue of CSULB, at which you're a lecturer, an educator, a provider of not only knowledge, but experience and expertise. They say knowledge could take you 1,000 miles, but experience will take you infinity. It's applying that knowledge to one's experience, which is what I see you really contributing to our kind of healthcare delivery infrastructure development. It's a mouthful, but cultivating the next generation of leaders. So I want the world to hear directly from you. Background. I know that you have an extensive background, ranging from international, you know, very rural healthcare delivery to metropolitan pandemic epidemiology, and would really like to have the opportunity to introduce you to the Carenodes network and all of our stakeholders at once. So please, introduction, since I don't do you justice.
Thank you very much, Alex. It is great to be here today. And as you very well know, I'm just a country boy. And some of my friends have called me the itinerant medicine man. I just travel, you know, peddling my trades. Not snake oil, but knowledge. And knowledge that will empower people to have better control over themselves. I go to a place and I typically go as a student. I want to learn, because typically you will tell me what is wrong.
Mm-hmm.
And telling me what is wrong means we are already at that phase of acknowledgement. So we're in a path, and that path of knowledge to know how we will sort it. Because if I come in as the all-knowing MD, my clients will shut down. Who are my clients? As an itinerant medicine man, I am not a physician for one, but rather of the community. I treat the community in a holistic approach, which is the principle and the concept we use in public health. You and I were discussing just on Friday before we set this meeting up. And we started with the discussion of access. What is access? Is it just getting that truck to pick my client or my patient or my individual from point A to B? Yes, it could just be that. What if they don't want to accept the care I'm providing? So it's beyond transport. We're talking about acceptability. It's beyond access. We're talking about beyond physical access. We're talking about the accessibility. What about affordability? Okay, they want my treatment, but they cannot pay. Affordability. What about that other one of adaptability? For example, you're talking about my international work, and I want to give a specific example that comes to mind right now. I ran a medical program with 26 clinics under me in Darfur during the war in Western Sudan. And one of my providers in the OBGYN wanted an obstetric bed in the desert. It is okay to ask for a bed, but he wanted it for his convenience. There was no point where he talked about the convenience of the patient. So I asked him, that woman in labor is your priority. I love you, bro, but I don't care about your back. If you need to bend or twist, bring that baby out. That is called adaptability. So we can go through the A series. A for access, acceptance, affordability, adaptability, and so on and so forth. But which is something that is missing. In at Castle Long Beach, where we met, and I'm fortunate to have crossed paths with you, we have a class in global health. In our global health class, which I'm fortunate to steer, the first day of class, I always ask my students the same question. What is health? Everybody will give me the standard definition, the WHO definition, and tell them you can use Google. Then we stop. Then we proceed to the next one. I told them, tell me the difference between international health, travel medicine, international health, and global health. And they start scratching their heads. Now, let me place it in context to make sure this awareness series, that we're having, dovetail. We started with travel medicine. In travel medicine, you just want to know, what do I need to travel to Saudi Arabia? What do I need to travel to Iran? What vaccines do I need? So it was more like tailored with traveling. Then it evolved to international health. But the tone of international health took part of travel medicine and took part of the colonial mentality. Let's go and save the world.com. So when you are free as a provider, you get on the plane. Let's use our 2 weeks in El Salvador, in Guatemala, or in Honduras, and let's save the world. Let's give those women that are climbing up those hills, high stiletto shoes, because it's free. They will take it. But do you really want to climb up those mountains with your high-heeled shoes from America? No. Do we want to just call them illiterate because we told them, which is important, to eat, to take the pills 3 times a day with food? Now you're confusing them. Who told you they eat 3 times a day? Who told you they can afford 3 times, 3 meals a day? Why did you come to that assumption and conclusion without asking first? So now tell me, who is illiterate? Then it now morphed into the new lingua. And that lingua right now is called global health. In global health, we're talking about the transnational nature. I didn't say international, I said transnational nature of diseases and disease profile, which is public health, which means the policy or problem in Brazil, before you know it, as far as a direct flight from Rio de Janeiro to Los Angeles, Zika will get to you. If it is weak in China, if there's a direct flight to New York, it will get to you. And you cannot build any border wall, because all you want, for example, our virus will not ask for permission or visa to come to the US. If it had asked for visa, we would have said no, but it will not ask. So that is the metamorphosis right now. The virus will not ask for permission. The birds carrying SARS will not ask. And I mentioned SARS because it's a SARS-CoV-2 virus, the same as the SARS virus we've had. And we call it the COVID-19 because we're referring to the epidemic that we determined in 2019. That is why we have the COVID-19. And it has not ended. Now, interestingly, calling it a pandemic does not make it severe. The highest point has already been declared by the World Health Organization in the first quarter of this year. And what is the highest point? It was called a public health emergency, of international consequences. So it was an international public health emergency. This is actually at stage 4. So calling the pandemic only describes a geographical spread. It does not describe severity. It had already been declared severe. So when people heard the word pandemic, they think that is a bad word. No, the bad word was the one they ignored. So going back to our conversation on Friday, we're talking about I's: information, communication, and education. And that is where the thing stands right now. And I remember on Friday, you told me about the Mental Health Awareness Month, which very, very strangely, I was not aware of. So I'm glad you educated me on that. And, that has made me to think about a lot of things also. So I'll let you ask your next question.
Yeah, no, I mean, this is great. Same situation with me. I was in my elevator, beginning of July, in my building elevator, about to lose cell service, and I was refreshing my emails. And I see that from Psych Hub, actually, which is a great resource. We're a Psych Hub partner. Um, Amazing educational videos around psych matters. And I guess it said Minority Mental Health Awareness Month. Now, I thought, oh, wow, the present protests, and this is in 2020, present protests have given, a designation to July as Minority Mental Health Awareness Month. Little did I know, since 2008, July has had such a designation. 2008, and so me being a healthcare person, being a leader in behavioral health, um, being in this industry for some time now, and I could use some behavioral health services myself. I had no idea that July had Minority Mental Health Awareness Month, which is a very long description. And it's interesting that it's called minority because when you look at the globe, when you look at the United States, we're almost all minorities. Whether you're a
Yes.
minority in the rural, parts of the land, whether you're a minority by virtue of your colors, whether you're a minority by the virtue of your designation as, this type of person who espousing that type of sexual orientation and on. It's important for us to make sure that we are using our platform to help guide our collective response in a way that is sensitive to mental health, that is sensitive to the sociocultural implications of effective and certainly not destructive healthcare delivery system. Now that we're using virtual, now that we're using, we're in a entirely different era, entirely different era. It should really be COVID 20, not 19 for us. But it's important for us to use our platform to go ahead and amplify and raise awareness, just how both you and I were not aware that July had such a designation, and both you and I have good reason to be aware of such a designation, not only in our profession but also as folks of color. Somehow, our mental health needs awareness because of all these other factors. So, I want to hear from you. What are the challenges in accessing behavioral health care in a cultural context, whether it's whether it's geographic, whether it's sociocultural? What are some of the ways that then we could break through those barriers, which you've already pointed out? Awareness is one of them, but I want to kind of expand it more and let those outside of healthcare, such as those in technology, who want to contribute in the delivery of care, for them to also keep in mind that as we're feeding our algorithms books from the time where racism was a common, well, it's still a thing, but back then when it was blatant, we're teaching these machines and these algorithms to be racist. And how do we consider the element of minority and the nuances in our development of
Mhm.
technology?
Yeah, it's a very interesting question because what the current epidemic and pandemic has exposed is our underbelly, the soft spot.
Mm.
Uh, I'm glad you mentioned, the racial tension and the demonstrations in the recent months. And let's go on a journey and think about the days of our public school days. At what stage did we start having police officers in schools? Why are they called resource officers? That was the question I did not ask you on Friday when we spoke.
That's
At
a
what
point.
stage did we take discipline away, ability to discipline from the teacher, that we need to call a cop? So that mindset, the police is not set for that.
Mm.
You have siblings, I hope, just as I do. If they act up, my mom will not call the police.
Mm.
My mom will pick a broom and knock their skull out. But you call the police, and the police, the first thing they do is they come with a gun. They'll tell your brother or my brother to drop that broom or drop that gun, or well, hopefully not a gun, drop that knife or something, or even drop that pen. And if he moves towards them, they will shoot him. At what stage did we start outsourcing? And why does this happen mostly in minority schools, black and browns? Why do we not have the same resource officers in white schools? And why will a white shooter shoot people after Sunday school or Bible study, and the cops stop and bought him a burger on his way to jail? Not only did they, in quote, arrest him, but they stopped because he was hungry at Burger King and bought him burger. But you have some other people just walking away, but they are shot at the back. So you must think of the systemic issue. You are talking about fixing a system. What if the system was originally made this way? You are not repairing it. You have to just reconstruct it. Now, to address your question on minority health issues, this is what COVID-19 has showed us. Because in COVID-19, still the people, black and brown, that are most affected. And one of the reasons why they are most affected is because of the social, economic, and cultural factors. In the Middle East, we'll call it fatul. We stop in the morning, 10 a.m., all of us eat together. Our breakfast, we actually break the fast. We sit down around the common table and eat. We do that. We still do that in Africa. The Mexicans and Latinx, they'll sit in front of the house or at the backyard. Everybody still congregates. Plus, they are the driver of the informal economy. Being the drivers of the informal economy, no work, no pay. There is no other thing, no work, no pay. Are you going to tell me go in peace and say no more and wait for COVID? How will the food come to your table? So we have to be realistic. Now, from the healthcare perspective, having said all of this, we have to now transition to the behavioral health component of the issue. Top on the list in behavioral health will be the health-seeking behavior. And the health-seeking behavior is premised on trust. They don't trust me, period. They don't trust you too. So if I'm not trusted, I'm wasting my time. They've been abused multiple times. The Tuskegee Experiment is one, where deliberately young airmen, Black people, were inoculated with bacteria to see their response. Or the one in Guatemala, 74, 75, and 76, gonorrhea and syphilis, to see the effect on pregnant women. So how will they trust us? And people telling about vaccine, there are justification. For example, the CIA ran an operation, and to positively identify Osama bin Laden, they needed DNA sample. What did they do? A fake vaccination campaign door-to-door, hepatitis, in Abbottabad. They started from outside Abbottabad, and they moved to Abbottabad just to make sure they can retrieve samples from any child in that compound, which positively ID'd that was related to Osama bin Laden, because they already knew it was there, but they needed a possible ID. But they chose vaccination and public health tool. Now, you tell me, if you are a neighbor in Abbottabad in Pakistan, and I, as a public health officer, come to you to try to vaccinate your child, what will you tell me?
Stay away.
Yes,
yeah,
exactly. So you can see it's a marinade right now. We're looking at the health policy. We're looking at health-seeking behavior. And we're looking at the actual implementation. Now, back to COVID-19. I just want to keep on going back to COVID-19 and the mental health, which is the core of our current discussion.
Yes.
It has showed the disparity. It has showed that people are not being tested because they are afraid of their name getting to a database. And they think the government is just after them because the government has done it before. Now, in the organization that I lead for the COVID response, every test I cover San Bernardino, Riverside, Los Angeles, Inglewood, and Long Beach.
These are Southern California region.
All in Southern California.
Large region.
And I'm like an Uber driver. I start at 5 a.m. and I end at, wherever.
Wow.
Yes, I don't know how many miles I cover in a day with my teams all over the place. Now, in the population I cover, they are mostly Black and brown, disenfranchised, uninsured, or underinsured. So we just got a HPE from them, hospital presumptive eligibility, that covers them for 60 days. Just for being tested, you get an insurance. It's part of the federal government program. Yes.
Let's talk about, so first, are you doing COVID tests for the uninsured population?
Yes.
Are you getting reimbursed for that?
Not directly. This is why I said we use the HPE, the hospital presumptive eligibility, gives them insurance. But most people are even afraid to apply for HPE.
Yeah, no, I mean.
Because we told them it is free, but free means zero out of pocket cost to you, but somebody still got to pay for it. So if I can get any information from you, I will get it so that I can get some money in order to exhaust my grants.
Well, it's interesting because they say no such thing as a free lunch, right? So I think free is a word that when I hear rings kind of that way as well. But actually, there's a program through HRSA. Well, HRSA is a program and it's administered by Optum, United Health actually, where some of Carenodes participating providers actually are now receiving reimbursement for testing of uninsured individuals of COVID-19 testing. So,
yes, I'm connected to that program also with HRSA. And my major grant is also from HRSA.
Excellent.
Yes.
But part of what we do at Carenodes as a network really is to make sure that we are viable financially. And so, United States being one of the only country that has a profit element to healthcare delivery. So as long as that element is there, we need to have more people who are oriented in the mindset that is in alignment with equity, access, stability, healthcare delivery infrastructure that does not, does not discriminate, does not have disparities in access, in equity. For instance, talking about mental health or getting mental health services, accessing mental health services, these are steps that already are difficult for an individual who's experiencing such issues. Now, access to mental health really depends on the type of insurance, if any, you have. For instance, if you have, a Medi-Cal, or in California, a Medi-Cal, the Medicaid program in California is Medi-Cal. You have a Medi-Cal or a Medicaid card, and how are you going to find a provider? There's really no easy way to do so. And so you become discouraged. You're working your tail off throughout the day. And then at night, when you're feeling motivated, maybe to seek some help, then there's no one to pick up the call. Then there's no resource that you can easily go and find out. The health plan directories are out of date. How are you going to choose the long list of people that are listed here? You have to call during the day. And that becomes, again, a barrier to care. The fact that these are folks who cannot access the network because of the fact that their health insurance company doesn't have the network in place or the infrastructure in place for them to access. So it's becoming an exasperated issue, Godwin, in a sense where we're seeing folks who cannot afford the telehealth, folks that don't know how to access it, folks who don't know how to bill for it, and on the provider side, it's becoming more and more difficult to access health care services, despite the fact that we're becoming virtual. I feel like we're becoming in a way where, for instance, Medicaid. I don't know what telehealth Medicaid provider there is, for instance, for me to use my Medi-Cal card to go and see a telehealth provider somehow online. Maybe there is, but the person who's seeking that help is not going to go and care coordinate for themselves. By that time, you've already given up. You've already self-medicated. You've already whatever, right? There's a whole host of things.
Mhm.
But I think that men have particularly difficult times or difficulty, if you will, in one accepting the mental health issue that they might have, and then seeking care for it directly.
Mhm.
What do you think about the topic of mental health and how men, especially men of color, kind of interact with that concept?
Yeah, it's interesting because in the preamble to your question, you mentioned two key words. The first word you talked about equity. I'm glad you mentioned equity and not equality, because we cannot distribute, for example, two comprehensive health clinic in every county. That will not be just in California, because some people, because of the population distribution, the social dynamics factors, and etc. So it has to be on the needs basis. For the short person, you probably will give a high boot, and for the tall one, you give a flat shoe, and you arrange that. Then you also mentioned in passing one critical component of equity, which will be the advocacy. And in advocacy, you mentioned about navigators. You've already answered the question yourself. We come from a culture that is traditionally male dominated, as our Latinx family would tell us, it's macho, it's machismo. Boys don't cry. Boys don't admit they have pains. And these are the boys that grow up to be men. And when they are men, they will rather go to their grave than allow a nurse to see that carbuncle in their testicles. They will rather show someone else and say, hey, bro, I got this thing. What do I do? And they will self-medicate. So it is a societal factor. The society has wired us as men, and as particularly men of color, not to cry, because they think it's a sign of weakness, which clouds even my own health-seeking behavior. I'll carry a few bricks from my lawn to my backyard, but I have to tough it and not tell anybody I have back pain. What if at that point I've already slipped my disc? So health-seeking behavior goes beyond linking it to access. That is a clinic there. The clinic is there. But what if the clinic is run by female providers? I don't want to sit down and let them check my genitals, for example. That is now issue of acceptance and adaptation, because it is in my own mindset. It is not sexual in nature. It's just that I'm resistant to change the way we have been trained. So we have to go back to the first principles, to the element, which is really, really, really difficult. In mental health, in my first, when I start my class, I always ask my students in the beginning of the semester to talk about health, international health, travel medicine, blah, blah, blah. That's my global health class. Now, in my health science class, you know what I ask them? Who is your therapist?
Really?
Do you have a therapist?
Oh, wow.
And most times, nobody will identify. And I use it as a hard knock icebreaker. And I said, yeah, you want me to ask you, what's your name? What's my name? No, I don't want to ask you that one. I want to ask you, who is your therapist? Because we sure do need one, especially coming to my class at 6 p.m. or 7 p.m. to 9:45 p.m. You don't have any other thing to do at home but to come to school? Now you tell me, who is your psychiatrist? And they will laugh. I said, yes, you will laugh because I am stressed and I want to admit it. So if you are stressed, it is okay to admit it because I'm sure you have some other things to do than to come to a 7 to 9:45 p.m. class. 2 hours, 45 minutes to listen to me. I can't even stand me. So how are you standing me? Then they will laugh. Then the class will proceed from there. I can't stand me. At times I feel like sleeping when I'm talking. What about those listening to me? But I don't read from notes because I've already digested. I have prepared that each class is unique and I'm passionate and I love what I'm doing. It is being paid to be on a vacation because this is my vocation.
Very nice.
Yeah, you are paying me to do what I like to do. I will even pay you. If you don't pay me, I will pay you to be in school. So you can also ask me who's my therapist. I'm probably crazy. And I should not be afraid to admit that because it is not perfect. I've had meltdowns, I've had weak points, and I've seen people. Going back to your introduction, in international health and my travels, I've had colleagues that cannot reintegrate into the society. They just want to keep on working overseas because their comfort is just chasing that fire, alcohol, drugs, and some behavior I cannot repeat on camera because there is no outlet. There is no release in normal society. But what is normal society and what is usual society? So in the health-seeking behavior, especially in this mental health awareness month for minorities, the minorities are disenfranchised and the minority also have a lot of issues stacked against them, ab initio.
We're getting questions here
Yes,
from
ask your question.
um, our audience, and one is why is it important to see why is it important to consider behavioral health in delivering a network of variety? I think what the question is that our healthcare delivery network doesn't look like those which it's supposed to serve, right? And I this was a question that popped up here, but um, that's true. If the and it's to your point of about trust, if the delivery infrastructure, the folks there don't represent the folks needing the care, then there's a fundamental mismatch. There's more work you have to do in order to be able to proceed. It's interesting because someone walks in a clinic with diabetes. Oh, okay, let's set you up. Someone walks in a clinic with mental health issues. They're suddenly mental, and just because we can't measure it in a beaker, doesn't make it any less real. Doesn't make it any less important. Doesn't make it any worse. And I think that there is such a stigma that it you're scared to say, oh, you're experiencing mental health issues. You're like, okay, well, I hope I don't scare the clients. If I say that, they'll be like, this guy's crazy, I don't want to give him my project. um that's the level of stigma that we're
Mhm.
and so this audience person was wondering what you think about building trust in communities that the providers don't look like the communities they're serving, but those are the only people there. So how do you build the trust until you cultivate another generation?
Yeah, it's a very interesting question because we start with the definition of health. What is health? It is one of the definitions we use by starting with a negation. I will tell you what it is not.
Mhm.
And unlike other definitions where I tell you what it is. So health, according to the World Health Organization, is defined as not just the absence of diseases. That is, we start with a negation, but rather of that state of your complete well-being. That will include both your health, psychological, mental, social, even your spiritual well-being. So I'm starting by telling you it is not the absence of a disease, but the wholeness of that person. Now, health-seeking behavior in terms of access also means acceptance. It's a two-way street. Let me give an example. And this is a real example.
Please.
For some cultures, number 3 is bad luck. So there is this woman, let me just call them a Nigerian woman because I'm Nigerian. So let me just pick a Nigerian mother who is sick, and the son brings her to the hospital. And the son is agitated at the ER. Just so that there will be peace, the attending physician just said, you know what, I can't take you. Just put them in the crash bay. Just take them to the next room. Looking at the mother, just put them in the next room. And the next room was number 3. And in that particular culture, number 3 is bad luck. And the son holds his head. Oh my gosh, my mother is dead. My mother is dead. They put her in number 3 because the situation is really bad or whatever. That is one example. Let me now give a real example. I learned to be a physician, practicing or otherwise, but you did not learn to be a patient. So if in the Western culture, you come to me, I will ask for privacy and I'll try to talk to you. But if my mother goes to a physician in a culture, she has to act being sick, which also means she will go with her sister. You don't want to tell the sister to leave my mom for privacy, right? Because that is the support system she needs. My mom will be there, but my auntie will be responding. And the doctor in the paradigm should understand to say, hey, Mrs. ORKEH, how are you? And my auntie will respond, she is not feeling fine. My mom is there. Which means the adaptability under access is important. Which also means I will not tell, as a physician, I will not tell my auntie to leave the room. I actually need her. And she may come with her own sister too, so there'll be 2 aunties. And they'll all be in the room. And they're going to, and they'll finish each other's question. Did she eat today? One will say, no. One will answer, she ate yesterday. But my mom will still be in the room and just doing like this, acting the role. That is part of culture and health-seeking behavior. Now, in mental health and acceptance of healthcare, we have to be flexible enough to know that there are different cultures, there are different approaches, and in the community, I know the color matters. We cannot be colorblind because we've been built that way. But we should also understand the culture of the group of people we are attending to. So I'm not going into any place with my white coat, not even in America, with my white coat, my chest out, and tell you, hey, you do this or that. No, I can't do that. The way I will behave in Crenshaw district will be different from how I will behave in Beverly Hills. And you know that too.
Yeah. Yeah.
Definitely.
Sure.
So it is not, one size cannot fit all. And if I come in as a student first, it will help. That is why it is more important to talk about the community health to target mental health than the individual health to target mental health. Because when we talk about community health, we talk about social justice. We talk about equity. We talk about policing. So when I'm acting up, please call my social worker. Don't call the police. They will kill me. Especially I'm Black. They will shoot me first. And that is a fact.
That's what's in, yeah, statistics. And it's interesting because a question that we're getting here is psychosomatic symptoms. Okay, so essentially, my from the interpretation is that for the role play, the scenario that you just explained, how care is a family affair or it's more of a collective versus individualistic setup in parts of the world, even here in the United States, with certain cultures. How do you best address psychosomatic issues manifesting in the let's say primary care office or the physical doctor's office, but it's really a depression or some manifestation of a behavioral health concern. I don't even know how to call it a concern, illness. I'm still figuring out how best to refer to these things. But how do you help, for instance, in a situation where the patient shows up at the primary care and is showing us a headache, saying, I have a headache and a GI gastro issue, and happens to be a man of color, and might not even recognize it's his depression and anxiety that's making him feel that way. How do you break through that? At that point, do you see a male physician doing a referral to mental health, identifying that on the spot, considering all the factors?
Yeah, Alex, you always answer the questions for me. You make it very easy to have this evening of conversation. The top thing, which you've already answered, is called index of suspicion. When there's an index of suspicion, it means the physician or clinician or practitioner already has a level of awareness. He is trained enough to have that index of suspicion and so assist this client to navigate the labyrinth to seek care. When the physician has no index of suspicion, it will treat that back pain, but not the depression. Let me give an example.
Explain, yeah, index of suspicion.
Yes, let me give an example.
Example.
A million years ago, I was interning at an OBGYN clinic, and it is renowned for fertility or infertility, as the case may be, because we don't treat fertility, we treat infertility. Yeah, but it's a fertility clinic. Okay. And I have these clients. Typically, we have the female clients, of course, they are more proactive, they reach out, they want to have babies. And they come in to a fertility clinic and they complain of back pain. Come on. Is that really why you came to see me? Is that the real reason why you came to see me for your back pain? You say everything, but based on an index of suspicion, I'm going to ask all the questions related to pain and pain management as a clinician. Then I will now ask the other question about reproductive health. I will not start with reproductive health so that they are comfortable. And I say, question like, how many children do you have? Then they will tell you, that is the real problem. I don't have kids. Or I want kids or something. Because I'm in an environment where I'm already programmed to suspect the real reason or innate reason or unspoken reason. And that is more important than in back pain. So in depression, noticing depression, for example, somebody comes to me and tells me, doctor, I don't miss my clinical days to start with, but I love medicine. But so, say, doctor, I really don't sleep well. And I say, oh, yeah. Then I ask questions to about sleep pattern, about sleep structure, about even sleep location, or about the bed. But the person now tells me, every time I try to sleep, I keep on waking up. Okay. And we ask questions like what Americans will not ask: where do you sleep? What if he sleeps in a train station? I'm sure you will not sleep well because the train will pass every 45 minutes, for example. So there's an index of suspicion. I'm asking the unusual question before I now go down and boil down and say, okay, this is a mental health issue. But if you don't sleep well, I just gave you some lorazepam, diazepam, or whatever palm, and that is it. I'm not thinking there's a reason. For example, I can ask the person that has a back pain, as common as a back pain, to ask, do you have conversations with yourself? Do you feel some undue pressure? When was the last time you just did not want to get out of bed because of your pain? And they will tell me, oh, it's not only because of the pain, but I just don't have motivation. You see, now he has moved to motivation. But the first question, the presenting symptom was that back pain. But the back pain was because he doesn't feel like getting out of bed. Doesn't feel like getting out of bed because he feels hopeless, worthless, or useless. Or he hears voices in his head. So in our Western model, I claim I'm old school, but I'm not really old school. But where we were trained, we have this heightened index of suspicion to seek what the person is not telling you, to hear what they're telling you and find out what they are not telling you and help them. It's just like a child that comes for physical exam. She's perhaps 11 years old. You do head to toe, including the genitals. Then you find that she has an STD at 11 years old. What is my index of suspicion? The child didn't complain of rape or assault, but maybe the child is just being abused at home. So how do you find that information? You probably will speak with your nurse and tell the child to go and bring urine sample outside. Then the nurse will be able to separate the child from the parent or caregiver and say, if you have any problem, tell me, for example. Otherwise, it will still be the same caregiver or mother that will escort the child to the bathroom, and you will not have that opportunity. And the child is already in front of you. That is the best time to catch them, as an example. That is an example of index of suspicion. So for mental health also, it has to go back to the training of the practitioners and the physician. They should be aware that people will tell you things and people will not tell you things. The one they don't tell you is what they want you to hear. So back pain could range from mental health to infertility.
Wow. And so we're complex animals, and what a web we weave by the virtue of putting these systems together, and then not being able to, customize it in a way where because it considers those psychosomatic manifestations. I know that, like you said, best practices that we consider. I hadn't heard about the index of suspicion, so that was very interesting to learn about. And what you just educated me on. But it's asking to do more work, it seems.
No, it's actually asking to be well trained, so that you see a person in its entirety. I love shoes. So when I say you, I'll look at your watch, I'll look at your belt, I'll look at your shoes too. So, but rather than look at those three elements, your watch, your belt, or your shoes, what about if I just look at you completely? When you see a cobbler, or when you go in front of a cobbler, he's looking at your shoes, he's thinking he needs to fix that shoe, or he needs new shoes or something. When you see a tailor, we say, oh, that suit does not fit. But when we see clinicians right now, some people will tell you, oh, I'm a pain medicine. So it's tunnel vision. They prescribe the opioids, but you don't see the whole person. Yes, you are seeing an obstetrician. Yes, you are pregnant, but you are more than a pregnancy. How about your state of mental well-being? Now, let us circle back to COVID-19, which I keep taking us back to.
Yes.
Going back to...
I'm getting another question. Why is your background changing so much?
Okay, yes.
Yeah.
Going back to COVID-19, as we very well know, fear of the unknown is real. There are a lot of people who will wish to be tested, but they are afraid to be tested. Not out of trust issue, but just that fear of the unknown. What if they are positive? How would they deal? How would they isolate? What would be the stigma? Because earlier on you mentioned equity, then you mentioned stigma. How would their co-workers deal with them? Even the stress in anticipation is already making people sick. They can't cope with that. Then, post-COVID-19, not to talk about the residual deficits that have been described in the medical literature, but rather just the human deficit. Now, I've recovered, I've stopped shedding. Then I ask myself, am I really whole? Am I really there? Am I the same as I used to be? These are legitimate questions. We don't have the metrics right now, not because it's a novel virus, but we also are not even prioritizing it. We don't have the metrics. There is no off-ramp to address this issue. Do you know when you present yourself for testing and you have to wait those 2 days, 48 hours, 24 to 48 hours for your test, you won't sleep. And if it's beyond 48 hours, you start wondering, is there a reason why? Even that stress, then you get your results, then you are positive. In 2 days, God knows who you may have been in contact with. Then I tell you to isolate, and you live in a multi-generational household. Are you going to the hotel, or you just want to lock yourself in your room? How do you do that? And you know the framework is a tripod: test, isolate, and contact tracing. But if you wait 2 weeks for results or 3 weeks for results, how do you contact trace within those 2 to 3 weeks? Think of the stress on that person alone, minus all the other side effects we've been told occur with COVID-19. And currently, you may correct me, I don't think it's receiving adequate attention, especially this month, for minority health issue, because this is also a minority disease. COVID-19 is a minority disease in the US.
So when you say that it's a minority disease, should those who are not considered minority be more comfortable with the idea of COVID-19?
No, on the contrary, because the virus will not ask for permission. The virus can still cross any barrier, but they will have better access. And they probably will have a more positive health-seeking behavior, which the minority would not have because of history. They go to a waiting room, both of them have pain. A person of color probably will not have an ECG or CT scan done. But the other person will get the same treatment. that the other one could have received also. And they will just tell this one, take your pill or go. Or he probably has no insurance. And as you know, for providers now, unfortunately, the nature and the color of your insurance will determine the kind of care we will give to you. Yes, I have very good insurance by the grace of God. I have been very, very sick. I'm very fortunate to have insurance at the time I was ill. In fact, they asked me, what did I take from my illness? I said, because I had insurance. Because if I did not, I would not be able to pay the $50,000 required to take care of me.
Well, I'm glad that you look in the best shape ever, better than ever. So the insurance did its job and insured you. We have to bring the session to a close, um, since we're just on time. But I think that moving, what I really liked was Boys Don't Cry, and so we will do a session, perhaps a panel session on Boys Don't Cry, and we'll get some guys together and talk about the implication of Boys Don't Cry and the mental health and the well-being of minority as well as society, because we really can't have a happy environment if we're unhappy, right? So it starts with the self. So that's where we are, and this was a great for successful first live streaming out of the many series that are to come. And again, you're breaking ground. We're setting the standard. And do you have any closing words you'd like to share before we get off track?
Yes, because of the time and the era right now, it is very important that we go back to the first principles. Please take care of yourself. Be safe. Practice common sense and your hygiene promotion. You will not be wrong. Thank you very much.
Thank you so much.